Thank you very much for the opportunity to present a short overview of our clinical trial that evaluated an ultra-short course Primaquine regimen for prevention of Vivax malaria in PNG children. Primaquine is the only licensed treatment for Vivax hypnozoites in children. However, the dosing regimen can be complex. It often involves daily administration over a period of 14 days, which can be challenging for patient adherence. In addition, there is uncertainty regarding the optimal timing of administration of Primaquine in relation to blood stage antimalarial treatment. There is data available supporting the efficacy of Primaquine when co-administered with chloroquine or dihydroartemisinin piperquine, but the same data following artemether lumefantrine are scarce. Overall, it is acknowledged that the total dose administered is the main determinant in Primaquine efficacy. Recent trials have identified that short-course high-dose regimens are equally well tolerated and effective as 14-day regimens. Furthermore, in PNG children, our recent pharmacokinetic pilot studies have shown that a 3.5-day regimen of twice-daily Primaquine was also safe and well tolerated. The overarching aim of the clinical trial was to investigate the efficacy of a short-course high-dose Primaquine regimen that was given either directly following artemether lumefantrine or 3 weeks after for the prevention of Vivax parasitemia. To investigate this objective, an open-label randomised control trial of 220 children aged 6 months to 12 years who presented to the Alexisarfin Health Centre with uncomplicated malaria was conducted between September 2018 and November 2019. Appearance of any PCR-confirmed Vivax parasitemia following treatment due to any Plasmodium species at 42 days was the primary outcome and 84 days the secondary outcome. Children of eligible age who presented with fever or a history of fever were screened for malaria using rapid diagnostic test. All children with a positive RDT were eligible for recruitment, providing they also had normal G6PD activity. Recruited participants were allocated 1-to-1 to early or delayed Primaquine treatment groups based on computer-generated randomisation. At baseline, all children were given artemether lumefantrine twice daily for 3 days, with Primaquine administered either starting on day 3 for the early group or day 24 for the delayed group. Standardised face-to-face review was scheduled daily for the first 7 days and then fortnightly until day 84. At which times any symptoms or adverse events were documented. Additional data related to Primaquine therapy were collected on days 3, 4 and 6 for the early group and 24, 25 and 27 for the delayed group. The trial profile here outlines retention rates throughout the study and participant numbers available for primary and secondary analyses. This study showed that as assessed at day 42, early treatment was non-inferior to delayed treatment in preventing Vivax parasitemia following any malaria infection. However, the non-inferiority margin was not met at day 84, with a significantly higher proportion of children in the early group presenting with parasitemia prior to day 84. All children completed Primaquine therapy and no child required repeat administration after vomiting. From a safety perspective, there were no severe adverse reactions including hemolysis, and there were no differences in hemoglobin or net hemoglobin levels between groups at baseline and after Primaquine therapy. In relation to tolerability, vomiting and abdominal pain were commonly reported during Primaquine treatment, although both symptoms were typically mild and self-limiting. Of interest, we found that there were fewer gastrointestinal complaints when Primaquine administration was delayed by 3 weeks. The present data show that a novel ultra-short course, high-dose 3.5-day regimen was safe and had acceptable tolerability in PNG children with uncomplicated malaria due to any Plasmodium species. The trial also showed that a delay of 3 weeks may result in fewer relapses, particularly when we monitor out to 3 months after first presentation. Furthermore, delaying Primaquine therapy for 3 weeks also appeared to improve treatment tolerability with lower gastrointestinal adverse events. We speculate this finding may be due in part to children in the delayed group no longer suffering from acute malaria-related symptoms that may also contribute to nausea and vomiting. Finally, I'd like to acknowledge all study participants and their families, our wonderful drug study team and colleagues at PNG IMR, collaborators and funding partners for their roles within the study. Thank you very much.